To make sure we can cover all the content in the allotted time, we will mute everyone's line except the speakers and accept all questions through the chat window at the bottom of your gray toolbar. As an extra precaution, please mute your line as well by clicking on the green button next to your name. We'll devote about 15 minutes at the end of the presentation to questions. Please feel free to type a question into the chat window at any time. We'll read as many selected questions as possible to the presenters during the allotted question and answer time. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notifications. To introduce our speakers today, I'll turn things over to Professor Judith Darr, Chair of the ASRM Ethics Committee.
Thank you, Jessica, so much, and good afternoon, good evening, and welcome to everyone. It's such a pleasure as the chair of the committee to welcome you to our quarterly webinar series that the ASRM Ethics Committee presents. Today's topic is planned oocyte cryopreservation. In our field, we've seen a tremendous rise in interest and practice surrounding retrieval and cryopreservation of oocytes exclusively for use in the future. According to data published in November 2017 by the Centers for Disease Control, in 2015, approximately 20% of all ART cycles were for the sole purpose of banking oocytes, and this raises a number of clinical and ethical questions. The ASRM Ethics Committee has been interested and eager to provide guidance in this area, and we will do so formally later this year with the publication of an Ethics Committee opinion on the topic, which is currently in press. Today, though, we bring you three excellent and expert speakers to address some of the issues in this area, and we're very, very grateful for their willingness to share their clinical and ethical expertise. So our discussion today will be presented in three parts by the three speakers in the following order. First, we'll hear from Dr. Elizabeth Ginsburg, and she'll cover the epidemiology and scenarios in which patients are or are not candidates for planned oocyte cryopreservation. Dr. Ginsburg is a professor of OBGYN and reproductive biology at Harvard Medical School, as well as the medical director of the IVF program at Brigham and Women's Hospital. She's also chair of the multidisciplinary BWH Assisted Reproductive Technologies Ethics Committee, and I'm happy to say that she is a valued member of the ASRM Ethics Committee. Next, we'll hear from Dr. Louise King. Dr. King will cover medical and legal and ethical aspects of planned oocyte cryopreservation. Dr. King is a minimally invasive gynecologic surgeon at Beth Israel Deaconess Medical Center, and she's also the director of reproductive ethics at the Center for Bioethics at Harvard Medical School. We say she is a double threat in that she is trained as both a doctor and a lawyer, and she has extensive experience in ethics, both from a legal and medical perspective. She served on numerous and various hospital and research ethics committees, and we welcome Dr. King. Finally, we'll hear from Dr. Julianne Zweifel. Dr. Zweifel will cover social and mental health considerations. Dr. Zweifel is a clinical psychologist and faculty member in the Department of OBGYN at the University of Wisconsin-Madison School of Medicine and Public Health. Her clinical practice focuses on helping patients experiencing infertility, miscarriage, psychological struggles during pregnancy, high-risk pregnancy, stillbirth, and postpartum depression. She's a member of the University of Wisconsin School of Medicine Ethics Board and past chair of the Mental Health Professionals Group of ASRM. And again, happily include that she is a valued member of our ASRM Ethics Committee. And Jessica went over some of the housekeeping rules very briefly. Each of our presenters will speak for about 12 to 15 minutes in the order that I've just introduced them. And you will see their slides come up as they proceed through their presentation. We do welcome questions, and we often enjoy quite a robust discussion at the end of these presentations. And you can type your questions into the chat window in the bottom of your gray toolbar. And just as a plug for our committee, we do present these webinars quarterly, and we're very interested in hearing ideas that you'd like to see circulated and discussed at this webinar format. So feel free to reach out to me or Jessica and anyone at ASRM. We'd love to hear from you. So with that, I'm going to turn it over to Dr. Ginsburg to begin tonight's presentation. Thanks to all.
I do have a few disclosures that I have to list. They're shown right here. Nothing pertains to the topic of this discussion. The learning objectives are to be able to tell your patients about studies that have been done so far on elective egg freezing outcomes, and to be able to tell them what really the deficiencies in the literature are when we start talking about the potential likelihood that they will get pregnant from these eggs. It's clear from many studies done around the world that the majority of women are unaware of the magnitude of fertility decline related to their advancing maternal age. And in fact, surveys of gynecologists and OBGYN residents also have shown that many of our colleagues are not aware of the impact of age on decline in fertility. And often regular menstrual cycles are misconstrued as fertility. When we're talking to patients about elective egg freezing, the things that we often take into account and talk to patients about are their age, which, as you know, reflects the percentage of eggs that are going to be chromosomally normal or abnormal, their ovarian reserve testing, particular AMH levels, anti-Mullerian hormone levels, and antral follicle counts, which are the best predictors of response to ovulation induction used in egg freezing cycles. Their medical history. Are the patients healthy enough to undergo stimulation and retrieval? What's the likelihood of obtaining eggs in the context of their ovarian reserve and surgery or other biological or physiologic factors? And what's the likelihood of their eggs resulting in live birth? And this we aren't good at predicting still at this point in time, frankly. When the patients are consented, the ASRM Practice Committee has a guideline published on that. The following need to be discussed: ovarian stimulation and monitoring, what's involved with that, the side effects of ovarian stimulation, the risks of egg retrieval, the costs, including storage fees, because sometimes patients aren't aware that there are ongoing storage fees after egg retrieval. The future need for ICSI, injecting sperm into the eggs, is required when eggs are frozen, and the expected live birth rate per egg based on clinic data. And if the clinic hasn't had enough patients come back using frozen eggs, what's available in the published data. And there is, frankly, not much out there on that. The other things that should be included in the consent are with the disposition in case of the patient's death. The fact that a young patient is very unlikely to use her eggs, and I will show data on that. And the fact is that we're concerned that women might make life decisions based on a very limited number of eggs. There's a concern that women may think if they have 10 eggs frozen that they don't need to worry about fertility and they can try to get pregnant whenever, and age is no longer a factor for them, when in fact we don't know how to predict on an individual basis who is going to get pregnant and who's not. This is old data, but still holds true today. It's an ASRM practice guideline that was adapted from a science paper, just showing that the increasing risk of infertility with increasing age, and certainly the majority of the patients we see in our practice thinking about freezing eggs are in their sort of mid to late 30s, and unfortunately also early 40s, when the quality and number of eggs has declined. So there's no question that there's a need for elective or sort of planned egg freezing. So far, the randomized trials are still in egg donors. This is women in their 20s. The paper by Cobo et al. Published in, I believe, 2013 was really what led the ASRM to lift the investigational designation of egg freezing and showed equivalent live birth rates per frozen and fresh egg for obviously the eggs that survived freezing. So if an egg donor's egg in their study survived freezing, it was just as likely to fertilize as a fresh egg and just as likely when it became an embryo to lead to live birth. However, the women in their 20s are not the women that we're seeing for elective egg freezing. Most of the patients, again, are in their 30s to 40s. Looking at the SART data on donor egg, as we all know, egg freezing has increased and the use of frozen donor egg banks is increasing. And in fact, the pregnancy rates aren't equivalent in the way eggs are frozen in the United States. If you look at the live birth rate per recipient cycle, using frozen donor eggs, the live birth rate is 36%. compared to eggs that were fertilized, fresh donor eggs that were fertilized and then subsequently used in a recipient, and that's a 50% live birth rate. So although the large randomized trial in egg donors from a single very experienced center shows that the pregnancy rates are equivalent, I'm not sure that's necessarily true. And I don't think we necessarily have the data to support that. This was a study done out of the Shady Grove group where they looked at patients that had undergone oocyte vitrification in 875 women for various indications between 2014 and 17. There were 128 cycles, but there were various reasons for the egg freezing: lack of sperm and egg retrieval, fertility preservation for various indications, couples that did not feel comfortable fertilizing all the eggs at the time of retrieval. They actually also looked at they showed the number of the percentage of mature eggs that they froze. The survival in the different with the different egg maturations was equivalent, and they looked at egg maturation when they did in vitro maturation after thaw. And then looking at what the outcomes were, the patients were equivalent ages, those using vitrified eggs, and then patients just going through standard IVF. The body mass indexes were a bit higher in the sort of standard infertility population. And then looking down, you can see that the vitrified egg group had fewer eggs available. They reported out subsequently implantation rates, which were not different per embryo transfer. Unfortunately, they did not give data per thaw. It would have been nice to see that because we aren't sure whether, in fact, some patients aren't represented here because they didn't end up having embryos to transfer. But if they did have embryos to transfer, looking at that last line, live birth, ongoing pregnancy per transfer cycle, that was not statistically significantly different. So it looked like in this study, again, not very many cycles, that the pregnancy rates may be equivalent in sort of the mid-30s. Not surprisingly, there were fewer blastocyst transfers with vitrified eggs, I think in part because there is increasing concern that vitrified eggs do cleave more slowly, and especially if there's a very limited number of eggs, there's a tendency to want to make sure that the couple has an embryo transfer and isn't one of the unlucky ones with no embryos that divide between days 3 and 5. This is another study that was looking at elective egg freezing or planned egg freezing, and they looked at this was a single center. They looked at cycles done between 2005 and 2015, and they compared them to cryopreserved embryo transfer cycles. So the FOET group are frozen eggs that were subsequently fertilized and the patients underwent embryo transfer, compared to a group of patients having frozen embryo transfers. Obviously, the N is quite small. The FOET group was 42 patients, and some of the subsequent slides, they did do more than one cycle in some of the patients. The FOET group had a younger egg age, 34 compared to 36. The body mass indexes weren't different. Looking down, this just gives the ethnic split. And then if you go to table 2, this was looking at how the cycles went. Again, there were more cleavage stage transfers in the FOET group than the FET group. Again, I suspect this represents concern about having a very limited number of eggs and being concerned that there wouldn't be any blastocyst embryos to transfer. And again, this is just the reverse. And then looking at pregnancy outcomes, ultimately, this is a multivariate analysis, so they adjusted for age and other factors. And the live birth rates in this group were equivalent after adjustment. It was a 25% live birth rate with a frozen egg, and this was per cycle here. 25% live birth rate, that was 17, and 25% also in the frozen embryo transfer group. Again, it's a fairly low number, but just to remind everybody that this is going back to 2005 with a mix of day 3 and day 5 transfer. So it is, again, a little bit hard to know how that would equate to a current practice. Well, given that we're already doing elective egg freezing or planned egg freezing, you know, what's the best timing when we have patients come in? At what age do we think we should be encouraging them to freeze eggs, or at what age should we be discouraging them potentially? And this is a study where they did modeling using SART IVF data looking at average age of marriage, miscarriage rates over time, and they determined from this study that you were improving the likelihood of ultimate live birth if you froze eggs at age 37. And they thought that the improvement in the chances of having a baby was about 51% compared to 21.9%, which would be if patients were just undergoing IVF at that age, not having frozen eggs previously. Not surprisingly, the highest probability of live birth from frozen eggs would be if it was done at a very young age, but the likelihood that a very young patient is going to actually need to use frozen eggs is extremely low, because a young person is likely to become married and not necessarily be trying to conceive in her later 30s, when the infertility risk is much higher. There was thought to be very little benefit of freezing eggs ages 25 to 30, again, just looking demographically at the fact that those women would be likely to be married and not necessarily trying to conceive in their later 30s. The thought was, after this analysis, that it was most cost-effective to freeze eggs at age 37, and this was looking at the cost of IVF at different ages and comparing it to the cost of egg freezing at age 37. And the tricky thing is, if you look at, okay, freezing eggs at age 37 may be cost effective, if you look actually at that Ho paper, again, 68 cycles worth of data, if you look at the live birth rates at women that were greater than or equal to 38, it's less than 20%. So the problem with waiting and encouraging patients to not freeze eggs until they're older is that the quality of eggs is lower, and we are going to expect lower pregnancy rates. It may not be any different from frozen embryos, but you're not talking about very high pregnancy rates. So I think we do have a dilemma in that the younger the patient is, the higher the pregnancy rates, but the younger the patient is, less likely she is going to need to use them. This is a table from a paper written by our group. It was published in Human Reproduction last year, and it was done looking at modeling. Dr. Goldman and Fox obtained data from reprogenetics and was able to look at thousands of PGS cycles at different ages. And looking at that, looking at survival of mature eggs in our program, because we have been freezing eggs for quite a long time in our program, using both our egg survival data, egg-free and egg fertilization data, they were able to come up with this kind of helpful predictor, which I actually use quite often. If you look at MD Calc, they actually have an egg prediction model. You can put in the patient's age, AMH, and other factors, and sort of spit out the live birth prediction. And this was looking at probability of each one live birth. So for an example, for a woman who is less than or equal to 35, and the reason why that was lumped together is that reprogenetics didn't have a difference, a significant difference in aneuploidy at those ages, but 69% likelihood of one or more live births with 10 mature eggs were frozen. But if you look at 10 mature eggs in a 37-year-old, for example, that's only a 50% chance of live birth, and 10 eggs at age 40 only gives you a 30% chance of live birth. So this is based on modeling, but it is not real-time data, and certainly we don't have any randomized data that we can use to help our patients make their decisions. So that's all I have. I'm looking forward to the discussion at the end.
So I'm Louise King. Thank you so much for asking me to come forward and speak with you about the ethics of egg freezing. I'll touch a little bit on the law, but mainly focus on ethics. I have nothing to disclose. So my first purpose in talking to you is to give you a little bit of orientation to ethical theory in the event that you don't recall it from your training in medical school or never had it. When we speak of ethics surrounding a particular question, we think of 4 principles: autonomy, meaning somebody's ability to make choices on their own; non-malfeasance, do no harm; beneficence, do some good; and justice, let's ensure that we have fairness in our delivery of healthcare and our choices and medical options that we afford women. Those are the 4 principles. They can be a bit clunky to use. They're a little bit difficult to apply. But they're important, and they have historical importance. If you didn't know, they originated with the Belmont Report, which was in response to this Tuskegee violation. So the main thrust of them is honesty, integrity in our dealings with our patients, given that they originated in response to these abuses of our patients' trust. The Belmont Report actually divided them into 3, and autonomy was originally described as respect for persons. The reason I bring that forward is because autonomy does not mean every single choice one could have, and this becomes very important when we start getting into innovative practices, of which oocyte cryopreservation or elective egg freezing is one. Not all choices should be afforded to all patients, but where to draw the line can be very, very difficult to discern. Just to give you a couple more slides on ethics and ethical theory, I could go on forever about it, and I absolutely will not do that, but there are some newer ways of thinking about ethics. This book is an excellent read if you ever have time for it. It describes a concept called social intuition or moral intuition. And in a nutshell, that's the idea that we all have knee-jerk reactions to any ethical question that comes forward to us. And our reactions frequently are important. We need to take account of what those reactions are. They come from our years of experience, from our background, and we shouldn't ignore those. We need to think about them. Then taking this book and its theories around cognitive reasoning, there are 2 ways of thinking, and type 1 thinking is this moral intuition. It's that type of knee-jerk reaction that we have. Type 2 is when we slow down and try to analyze things, and that's when we can take our principles and use them and really analyze the question. So again, in summary, as we're thinking through this question of the ethics of egg freezing and what limitations maybe should exist or maybe should not exist for it, we need to take into account our initial knee-jerk reaction and also that of the public, their knee-jerk reaction as demonstrated through our experience with our patients or through our review of the lay press. And there's definitely a conflict. There are people pushing forward for oocyte cryopreservation for access to it, and there are people who have very negative reactions to it. Those are both very important. And then we need to use our principles and see what we think of it. So is it ethical to offer elective oocyte cryopreservation, and see what your initial response to that is? Mine is one of a slight trepidation, and I'll explain why. And then I'll apply my principles. Does it achieve good? Is it beneficent? And there are definite arguments in favor of that. Does it cause harm? No more so than any other reproductive REI procedure, probably, and so very little potential harm from a medical standpoint, but are there questions for social harm and justice? And we'll explore that really briefly. And does it promote autonomy? That's the big push typically. So as we look through the typical arguments in favor of oocyte cryopreservation and making this widely available, Dr. Ginsburg alluded to one of them, which is it could promote an understanding of the time course of natural fertility. We do know that our patients don't understand their natural fertility time course, and affording them information about oocyte cryopreservation as an option, along with education about their natural fertility, would essentially be a beneficent thing to do. We could certainly do it without affording them oocyte cryopreservation as an option, but it could have that benefit, which is wonderful. It might allow for more flexibility in life and career planning. Now, of course, this is a social problem, and should we be applying a medical solution to a social problem? That's debatable and certainly part of the ethics question that is presented. And we are allowing for more flexibility, but planning for a pregnancy later in life with increased risks. So that has to come into our balancing act. It comes potentially at the expense of other efforts. As we proceed forward with making oocyte cryopreservation more available, we decrease our efforts potentially towards advocating for more paternity and maternity leave, for advocating for flex jobs and more daycare. So does this come at the expense of fairness and justice in terms of gender equality? And does this promote traditional family structures? Dr. Ginsburg presented a paper that discussed the optimal timing in that of oocyte cryopreservation at the age of 36, 37, but that paper presumes that a woman would proceed forward with her reproduction in the context of a marriage. Well, there might be other family structures that we should be more open to. When I consider that question, I do tend to look the mother's age at first birth. And I've compared it in my mind to that in Scandinavia, where I know there's more access to daycare, to flex jobs, to a lot more flexibility within their social construct. And yet, if you look at this graph from UNICEF, the mother's age at first birth is actually older in Scandinavian countries, or approximately the same as ours. And that's taking into account our much higher rates of teenage birth. So it's not simply that we don't have options. We're redefining our social structure. And I believe Dr. Zweifel, I hope I'm pronouncing your name correctly, is going to be speaking to that a little bit more in depth. So there's more to it simply than this advocacy question of making sure that people have access to alternative options. So again, just as with promoting an understanding of the time course of natural fertility, we can allow for more flexibility in life and career planning by making oocyte cryopreservation available while still proceeding forward with efforts at increasing maternity and paternity leave flex jobs, and while still promoting different alternative family structures. Skipping to my next point, it might allow families to have genetically related children later in life. Again, this is an argument promoted in favor of allowing oocyte cryopreservation very widely. But why do we promote genetically related children, and what does this say about adoption? We all know that we tend to have a preference for genetically related children, and that preference is obviously to some degree a biological imperative. But if we are promoting that by allowing for oocyte cryopreservation, what are we saying about families that have been created through adoption and those children of adoption? A strong philosophical and moral argument can be made that preferring a genetically related child is actually unethical, and that we should promote not only for infertile couples, but for fertile couples, that we should be prioritizing adoption as an option. But I would say, again, we could achieve that while still making this option of oocyte cryopreservation available through efforts socially to make adoption less expensive and less time-consuming, and promoting it in that way while not yet limiting the option of oocyte cryopreservation. The strongest argument that's put forward is that, frankly, the public is in favor, and that these options of oocyte cryopreservation promote a woman's autonomy. If a woman wants it, they should have it, I've heard expressed. But as I'd mentioned, autonomy is not all choices at all times. Protecting a patient's autonomy is ensuring that they are fully informed of different relevant options, and they are aware of all the risks and benefits, and also all of these issues that I've just been discussing. Patients should be made aware of certain justice issues and social issues that might be implicated by their accessing of oocyte cryopreservation. So I would advocate that, along with the risks and benefits that the ASRM suggests patients should be made aware of that were discussed in Dr. Ginsburg's talk, some of the risks of the procedure itself, for example, and some of the lacking information about success rates, we should also be educating our patients not only of their declining fertility, but of the risk of being pregnant at older ages, the risk to themselves and to their potential fetuses. We also need to ensure that our patients are free of coercion in their decision-making in this regard. And this is probably the strongest argument, and one that is being debated most hotly in ethical circles around this topic. The advertising surrounding oocyte cryopreservation is incredibly aggressive and potentially misleading. These quotes are taken from a website from a private company that holds egg freezing parties. And some of these statements just can't be true. I mean, may help deliver dramatically higher pregnancy and birth rates is true perhaps from one perspective, but is certainly misleading. Life on your own terms, best gift to self ever. These are aggressive marketing strategies. The AMA had previously banned direct-to-consumer advertising. That was overturned from a First Amendment standpoint in 1975. But the AMA still provides guidance that physicians should not engage in aggressive, high-pressure advertising, and nothing should be misleading. So at the very least, in making this technology available to our patients, we need to ensure that they are receiving the correct, accurate messages about what this technology can afford them, and nothing that is misleading or misrepresents what these options may lead to in the future. And if we don't know what the success rates are, we need to be very, very clear about that. Finally, this slide is my last one. What I'm trying to get at in showing you this slide about integrated ethics is that our decisions and actions about allowing or making available oocyte cryopreservation are merely the tip of the iceberg, and underlying those are social issues that Dr. Zweifel will discuss in greater detail, and the systems and processes that we engage in ensuring that these options are made available in an ethical way. That involves our culture and our environment, and how we present ourselves as a society through the SRM, through documents related to it. So we need to balance the access that we might afford as medical professionals to women to this new technology against ensuring that all the information that they receive is accurate, and that they are all risks are fully disclosed. We need to advocate for less aggressive and more measured advertising to ensure that this technology is made available to women in an ethical way. We should share information very clearly about risks of pregnancy and childbirth later in life. We should promote potentially single parenting and adoption as options. And we should continue to advocate for better maternity, paternity leave, flex hours, daycare options, and the like as a better social solution to the problem at hand. That's all I have for now, and I look forward to your questions.
So I'm going to be wrapping up this series of presentations by talking about social and mental health considerations. And I do want to thank ASRM, the Ethics Committee, and Dr. Dar for involving me in this. So I have nothing to disclose. I have a number of learning objectives. I'm hoping that at the end of this very short presentation that folks are able to describe the women who are interested in oocyte cryopreservation, including what their goals are and what's influencing their decision. I'm hoping that folks will be able to recognize how society is defining these women and how that compares to what we seem to think we are learning through research and clinical practice. I'm hoping that folks will recognize the social narratives as well as the economic and workplace messaging that is impacting women, as well as understanding some of the psychological risks and concerns of women who are pursuing egg freezing. And lastly, I'm hoping that people come away with ideas on how to best support women who are considering oocyte cryopreservation. So the mainstream media and marketing materials of clinics, as well as medical literature, portray a few consistent themes of women who are considering egg freezing, and they include the fact that these women may be vulnerable to exploitation, that these women may be putting their own selfish needs ahead of more important priorities, or perhaps that they are liberated and forward-thinking. I would argue that women are very aware of these narratives and are quite likely impacted by them. When we examine these portrayals through a social psychology lens, a couple of themes are evident. And one is the idea that having a child is central to a woman's identity. So much so that this imperative makes women vulnerable to unscrupulous clinicians, or alternatively, that the imperative is so strong that women should be prioritizing having children now rather than freezing their eggs and waiting to have children. Or lastly, that every woman should be interested in what's put out there as fertility insurance and want to freeze their eggs. Another is a judgment issue. And that theme is that, as mentioned, women can be vulnerable, and few women are very happy with being portrayed as vulnerable. They might also be caught between meeting societal expectations to reach educational and career goals, and yet end up being viewed as selfish for meeting these career goals and then delay having children. And there's also a sort of positive judgment, if you will, that it is the smart, take-charge women who will leverage reproductive technology to attain both career and family-building goals. And I think that's a little bit coercive, because who doesn't want to be viewed as smart and take charge? So what are women saying about their desire to be a parent? Well, in 2012, Peterson surveyed college students, both men and women, about this, and they found that, by and large, men and women still strongly rate a desire to have children. And if you look at women, almost everybody wants to have their first child by the time they're 34, and in fact, 75% of the women wanted to have their first child by the time they're 29. and men weren't actually all that different. Most men wanted to have their child by the time they were 34, and over half wanted to have that first child by the time they were 29. So in short, women still want to have children, and they aren't really expressing a strong or desire to delay. So what's going on? So I would argue that there's a rate-limiting step that's in place here, and that is trying to meet a set of prerequisites that people feel they need to create a stable and positive experience for themselves as parents, but also for their hoped-for child. And that, of course, includes having a partner that's willing to co-parent, developing a stable relationship between the parents, as well as attaining some financial stability and job security. Now, if you look at women, they actually report that if they were able to meet these prerequisites earlier in their lives, they would actually go ahead with having children at a time that more closely matches their stated desired goal. So this is not simply a preference to delay parenting. What we also know from research is that women are experiencing multiple pressures. And one obvious pressure is the awareness of their biological clock ticking and a fading of their fertility potential. There's also, though, a concern that a woman's worry over her biological clock may be perceptible and may be a turnoff in dating. So ironically, this exacerbates the whole finding a good partner thing. And making this point, Martin in 2010 has a quote saying, "The message that freezing eggs is out there, and it makes women feel more confident, and they believe they're going to appear less desperate, and that this may make them more attractive to women." And then locked on top of this pressure is the overt or assumed pressure to bring grandchildren into the lives of their parents. The support of parents in terms of financing egg freezing can be generous and well-intended, of course, but does it add to a sense of urgency to have a child? And I would argue it does. And then exacerbating all of this is the implied messaging from corporations. Although truly, currently few women are employed by companies that are offering subsidized egg freezing, it is a perk that has actually garnered a lot of public attention. But I think it's questionable whether this is really an empowering opportunity or a benefit to women. It might be for those women who actually want to have a child later in life, but for those who actually prefer to have their children earlier, I think you can argue that it's a subtle enticement to devote the most fertile and perhaps most productive years of one's life to the company and to allocate later lower energy years to a hope for a child. In fact, some people have described this as paying women to keep them unpregnant, or as a bribe that companies might pay in exchange for the valuable years of a woman's life. But there's also some backlash here. So there's been a lot of social commentary about the breakdown of family and family values, and it has been suggested that women's increasing pursuit of educational and career goals are causal factors in the breakdown of family. And that's a heavy burden. So what we know is that people are marrying later and having kids later. And part of it is that they feel that there's more that they need to do to be ready to have a child. So we have a lengthened process for the readiness to have a child. And that understandably leads people to anticipate that they're going to have their children later in life, which makes it look pretty enticing to consider fertility preservation. But I think you can ask whether the solution, fertility preservation, actually exacerbates the problem. Lamont and Revitsky point this out in 2015. And what they're suggesting is that egg freezing may actually be a false promise of preserved fertility and may actually contribute to decisions to wait longer to start a family. So basically, the argument here is that if egg freezing becomes more acceptable and commonplace, it may lead to the acceptance and greater postponement of having children. And it may also lead women and men to see more breathing room as they are trying to strive for this higher level of readiness to have a child, and they may seek higher and higher levels of readiness, which then, of course, leads to more postponement. What about the demographics of women who might be considering freezing eggs? So in just a study that was published in June in Fertility and Sterility by Greenwood et al., they looked at 201 women that had frozen eggs, and what they found was that these women were on average 36 and a half years old. Most were 34 to 40 years old. They were single. They were heterosexual. They were Caucasian. They were really highly educated, and they were making very good incomes. Now, they got in touch with these women on average 2 years after freezing the eggs, and they asked them a few important questions. One is they asked these women whether they'd had enough information at the time they decided to freeze eggs, and by and large, most women agreed that they had enough information. And furthermore, most felt that they'd received adequate emotional support at the time that they were going through this, although a smaller portion disagreed with the information and emotional support. By and large, the majority of women did report a sense of feeling an increased control over their reproductive planning as a consequence of freezing eggs. And most were clearly happy that they had frozen their eggs, even if they didn't end up coming back to use them. And indeed, women really are well aware of the fact that they may never use their eggs. So in the same study, these women were asked, what are the chances that you're going to come back to use your eggs to try to get pregnant? And what you see here is that most women gave it a 50-50 chance. So a lot of women don't anticipate that they will be using those eggs. In the same study, they also asked women about the latest age that they could see themselves coming back to have a baby. And on average, people were saying, about 43 years. The range, though, went up to 65 years. And I think that's an interesting point because I wonder whether the clinics that are freezing these eggs actually would offer an embryo transfer to somebody who was as old as 65. So what about the fact that there might be some regret? Well, we know from this study that mostly women are happy that they froze their eggs, even if they never use them. Really, most of them, nearly 90%. However, almost 50% are also reporting regret, some mild regret, and some moderate to severe regret. What we know is that the women who were reporting regret were more likely to have banked 10 or fewer eggs. They were more likely to feel that they had not been adequately informed or supported. And these women seem to estimate a lower likelihood of achieving a live birth with their banked eggs. There's also some psychological risks and concerns associated with freezing eggs. And one is these women might be experiencing some level of defensiveness and anger regarding what the egg freezing, which could be considered an opportunity, but I could argue you could also consider it a predicament. They may also be feeling singularly responsible to balance the societal change with family building goals as well as fertility treatment, rather than men or society in general shouldering some of this responsibility as well. These women might also be experiencing unrealistic treatment expectations regarding the complexity and ease of treatment, the cost, the likelihood of success associated with egg freezing, as well as ultimate IVF treatment. And the assessment of having your fertility assessed, your AMH and your antral follicle count, is an anxiety-provoking experience for women. By and large, women who are pursuing fertility preservation are presuming that they have good fertility potential, and they view themselves as actually proactively preserving their fertility. And these women, by and large, are completely unprepared to learn about diminished ovarian reserve. And when this happens, when they find out their fertility is not what they presumed it to be, they may struggle with the disparity between perceived youthfulness and ovarian reserve. And of course, there's always the risk that if they do not end up being successful in having a child, either during the fertility preservation process, it becomes evident at that point, or later through IVF, they may experience considerable grief. So, how can clinicians best support women considering oocyte cryopreservation? Well, one thing I'd encourage folks to keep in mind is that even though it may be viewed as an opportunity to take control, that is, freezing your eggs, these women may actually be feeling a sense of loss of control over their fertility, and they might be feeling risk to their life goal of having a family. Furthermore, I'd encourage folks to convey a sensitivity and recognition of the multiple pressures that these women may be experiencing. And I'd also strongly encourage that folks be cautious about the natural desire to convey hope and respect for reproductive autonomy with the need to convey realistic treatment expectations. This, of course, needs to include thorough informed consent, which really emphasizes the fact that fertility preservation may not result in a live birth. Of course, fertility preservation inherently suggests that people are going to have children at a later age. Therefore, education at the outset needs to include discussion of the risks of delayed pregnancy and delayed parenting, not only from the parent perspective, but including education about the impact of delayed parenting for the child. And lastly, I'd be suggesting that there are a lot of risks here, and a lot of them are psychological. And for that reason, I'd be suggesting that routine psychological consultation be provided to women who are considering freezing their eggs at the time that they are pursuing egg freezing, as well as when they return to pursue IVF. And so with that, I'm going to bounce it back to Jessica.
We will now open up the floor to questions for our panelists. Please send in your questions for the presentation through the chat box located in the gray toolbar to the right or the bottom of your screen. And our first question is for Dr. Ginsburg. Can you address how the conversation with an interested woman might change if more cost-effective options for oocyte cryopreservation were available, specifically about whether they should do it and at what age?
So interesting, because we talk about this from an ethical standpoint, and from an ethical standpoint, I guess the question I would ask is, should physicians play any role in worrying about a patient's finances? If we're there to give our best medical advice, should our perception of a patient's ability to pay even factor into that? It does come up in conversations, and I feel a little bit uncomfortable that I might be speaking more positively about egg freezing to a patient who I know has unlimited resources than I might to a patient who might have more modest resources. I'm not sure that physicians really should be taking a stand on a medical advice based on what something should cost. I'm curious to see what the other panelists think, but this is something I often grapple with in practice, actually.
This is Louise. I think it's important, obviously, to give patients all the information that's relevant. And so when you're talking about the financial considerations, given that this is an out-of-pocket expense, it has to come up. But I absolutely agree with what you're saying, Dr. Ginsburg, that you don't want to give a varied interpretation. You don't want your understanding of someone's financial situation to then cloud even in unintentionally what you're offering them. So just keep that in mind, as we do with all of the biases that we have, that you're going to have to know what someone's financial situation is to discuss this option, and that they should still be afforded every potential option, but that they may not be able to afford everything that you're bringing forward as a potential. I think when we're talking about the cost effectiveness of it, though, in each iteration of this question, I've seen that the balance always has to do with what would be the age at which you're most likely to use your eggs in a married situation, and then how close can you get to that age so as to save money, because of course you have to store the eggs. And again, although I know that the vast majority of women in the study that Dr. Zweifel was just presenting would say that they would want to have children in the context of a stable married relationship, yet still I think that there should be some studies that are done where you evaluate the cost effectiveness for women who might be willing to proceed forward as single parents.
And I think the other comment I would make is that when I see women regarding oocyte cryopreservation, I actually do talk about donor inseminations at that point. I would say maybe 1 in 10 women thinks about it and decides that she is, in fact, ready to parent on her own. But I think that should be part of the conversation.
I'll just add one thing in terms of the financial issues, and that is that I've come to learn over life that everybody decides how to spend their money. And people spend their money differently and see value in different things. So when working with somebody who does not appear to have the same financial means that you might think is necessary for this, they might feel it's attainable. They might make decisions to make it happen. And it might not be a decision that I would be comfortable with, but it still might be something that suits them.
The next question is, do you think oocyte cryopreservation should be covered by insurance? Should that be based on the patient age or circumstance, or is it purely elective for all women?
This is Liz Ginsburg. I can say that in Massachusetts, insurances do cover fertility preservation if there is an imminent threat to fertility. So that would be chemotherapy, facing potential bilateral salpingo-oophorectomy in a patient with endometriosis, other forms of radiation treatment for other diseases. So only in acute situations is it covered. I think the cost-effectiveness studies will potentially change that. If it's clear that a woman at X age is unlikely to ever be able to do IVF short of donor egg, and there's studies showing that it's cost-effective, I could see insurance companies coming around and starting to pay for it, because it's all about the cost to the insurance company. That's the reason why, for example, in Massachusetts, most of the insurance companies no longer require intrauterine inseminations prior to paying for IVF, because IUI was found not to be cost effective due to the low pregnancy rates associated with it. So I think time will tell. I could see that happening at some point when the data are better.
This is Julianne Zweifel responding, and I would say that the concern I have with the prospect of preserving fertility when it's not at risk due to medical conditions is that we might be solving a problem that might be better solved through different means. And so to me, it feels a lot like kicking the can down the road, putting off having children and finding strategies to make having children later doesn't really solve the dilemmas for why people are not able to have children earlier or what the impediments are. So it's not that I'm exactly against insurance per se, but I'm more for finding other solutions to the problem.
This is Louise King. I'd just like to second what you just said, Dr. Zweifel, but then also say that the counter to that, and actually your position is the same as mine. I worry that insurance coverage for this would detract from any efforts to solve the social problems that underlie this issue. On the other hand, from a justice perspective, of course, only those who can afford it can now access it. So there's certainly an argument to be made to make it more widely available through insurance programs. It's a very difficult question, an excellent question, so thank you for bringing it up.
Our next question is, given how egg cryopreservation has entered the realm of social media and the millennial generation of women are aware of this as an option, is it reasonable to anticipate that we'll observe increasing consumption of this technology? Is egg cryopreservation now a firmly integrated piece of a woman's health care?
I'm not sure who that question's directed to. I don't think it's considered a standard. I don't think that the general internist should be expected at this point to talk to every young woman who's not married or not partnered about when she's planning to have kids and doing elective oocyte cryopreservation. So I think it's increasingly commonly used. Do I think it's part of mainstream health care? Not yet. I don't know what the other panelists feel.
And this is Louise. It's definitely not firmly integrated at the moment, but it's definitely on the rise. And also many of the companies that are marketing this are actually publicly traded companies. So there's a big debate currently about whether this constitutes part of healthcare delivery or part of a service delivery. Is this really a marketed service as opposed to something through healthcare? That's part of the debate currently in ethical circles. I would hope that it would always remain within the realm of delivery of healthcare, so as to preserve the ethical underpinnings that we've been discussing surrounding its offer.
And this is Julianne speaking, and I would say I don't think it's integrated as a routine component of care at all. And I don't object actually to being a part of things. I think women should be aware of all their options. However, I'm going to point back to Liz's presentation and when she pointed out that people are not aware of their fertility decline. And so I would argue another important aspect that is central to why this is coming up is that people don't really understand their fertility and age-related declines. And that really needs to be addressed, not even just through routine well woman visits, but actually changing our educational structure in terms of how we teach people things. So I'd suggest we need to educate women better about a lot of things, and fertility preservation can be one of them.
Thank you. The next question is for Dr. Ginsburg. Is the AMH level a reliable predictor or adjunct predictor of when to initiate fertility preservation? Does it make sense to measure periodically?
That is an excellent question. It's a very, very good predictor of response to ovulation induction. And so for people experienced with ovulation induction, we expect a particular range, sort of egg range with particular medication dosing at particular AMH levels. With that said, we know that the AMH is going to go down over time. I do have patients that are very concerned about their sort of fertility, and it's a very poor predictor of fertility. It does not predict the ability to spontaneously conceive at all. It just predicts response to ovulation induction. And I do have patients that are on the fence about freezing eggs and do like checking the AMHs over time. I've had patients, for example, have AMHs in the 3 to 4 range, which is fairly high, feel quite comfortable with that, see their AMH, go down to 2.75 over a course of 6 months or a year, and decide that they're still likely to respond well to ovulation induction. They see the downward trajectory and decide that that is something that's going to tip them over into determining whether to freeze some eggs or not. But it's an excellent question, and I think the other thing that's tricky is that age is really a better predictor of an egg leading to a baby than the AMH is. So for example, a woman who is 43 with a high AMH is still going to have a fairly low live birth rate for that batch of eggs. So the only concern I would have about checking it periodically over time is that age is not a good prognostic sign, even when the AMH is good.
Thank you. Now for the last question. This question is for Drs. King and Zweifel. You mentioned that using a medical procedure to fix a social problem can be problematic and advocate for better social solutions to avoid the need for cryopreservation. But data, most recently a study from Yale presented at ESHRE, support that women are choosing oocyte cryopreservation because they've not found a partner with whom they'd like to parent. What kind of social situations would you envision that would alleviate the pressure that might lead a woman to oocyte cryopreservation?
I'll take a stab at that. So this is Julianne Zweifel speaking. So I've actually looked at information on how dating has changed over years and what people are looking for in a lifetime partner, which of course affects age at marriage. And what people are looking for is changing slightly over time. So it's been described this way in that people are now looking for a, quote, pure relationship. I can't actually describe for you what that means because I don't entirely understand it. But I think people are sort of upping the ante, shall we say, in terms of what they are seeking in a mate. Also, I feel like people feel like they have more time to find a mate. And so when they're dating in their, I don't want people getting married in high school, but when they're dating in high school and in college and in their, their young adulthood, I think that it's a different mindset. It isn't so much about, I wonder if this is going to lead to a lasting relationship. I think that they are believing that looking for a lasting relationship is something they're going to do at some chunk of time later, a chunk of time later that is later than their parents' generation. And so I think that's what's going on. And I think in part that's because people believe it's actually perfectly reasonable to have this expanded time frame. If you look at the research on developmental psychology, it's been suggested that there's a new developmental phase called emerging adulthood that is squeezed in between very late adolescence and young adulthood. So it's something that was never described before, but now all of a sudden it's being suggested that there's this new developmental phase. And if you accept that, then that's going to take up a certain number of years. So I believe that in part this is happening because I think people feel it's perfectly reasonable to have children later in life. And I think that's because the media is portraying delayed parenting in a very positive way. And what I don't think we're really hearing much yet about is the impact for the children who are conceived by parents who are much older. There is some data about it, and I'll tell you this much, they're not happy about it. They wish their parents had been younger, but that's only emerging, and those are just kids. And what I think is going to happen is that those kids are going to get older, and the narratives are going to start to change a little bit, and we're going to learn a little bit that pushing off parenting and kind of pushing everything towards the later decades of your life isn't really all that great for the children. And so what I'm trying to get at here is that I think doing a better job of educating folks about the consequences of delayed parenting, not just the health consequences for them, but the consequences for their children, may get them to approach their earlier years with a little bit different mindset of, oh, you know what, I'm not just going to kind of, not get too serious in my relationships. I'm not even going to think about anything serious until at least my mid-30s. I think we might see a change in their mindset. So it's a very long-winded answer, but that's my response.
This is Louise King. It's an excellent answer, and I think that is a good summary of what's happening in people's minds. Our role in creating different social solutions to this problem is, as mentioned, in education. Educating people that of everything that Dr. Zweifel just described, that delaying child bearing and childbirth is not good for women, potentially not good for their children. And I think also involving in that discussion men, where are they? If you adhere to this idea that the family is going to be a woman looking for a mate who is either a male traditionally or in many instances not a male, but in any event looking for a mate, when we're thinking about these heterosexual couples, we need to think about where these men are in this conversation, because frequently they are the ones who are also delaying and engaging them in understanding that women don't necessarily have the same options that they do, and whether I wish that were true or not, it is just a fact. So engaging all of our patients in this conversation about our changing understanding of this, and then finally advocating, even as a society, whether it's the ASRM or ACOG or any of the groups that deal in women's health, for better maternity leave and also better paternity leave, and access to alternatives within their employment structure so that they can have more flexibility would be incredibly beneficial.
Thank you. One more question came in that I'd love to pose to the panel. It's to all the panelists. If women cryopreserve their eggs and later find that they do not need to use them, what do you anticipate will be their choice of disposition? Discard, donation?
It's Liz Ginsburg. Well, it depends on what the FDA regulations are about egg donation at that point. Right now, people donating sperm, eggs, embryos to another non-sexually intimate partner have to be screened for sexually transmitted diseases. For women within 30 days of the egg retrieval, at an FDA-approved lab, so by analyses performed at an FDA-approved laboratory. If it's a non-anonymous situation, that can be waived and the testing can be done subsequently, but the way the FDA regulations are written right now, donating them to another couple would not be an option. We certainly have had patients already donating cryopreserved eggs for research. So that's something that certainly could be done.
Thank you. And thank you to all our presenters and attendees. This session was recorded and will be available on our website in the near future. Please keep an eye out for the announcement of our next webinar topic. For any further questions or comments, please don't hesitate to contact me at asrm@asrm.org. Attention, Jessica. And this concludes the webinar.